I'm Dr. Mary Lynn Knighton, and I am a lead patient family advisor at St. Francis Medical Center. And I do a bit of consulting and I do a bit of teaching at a doctoral level in 2 universities and some community work as well. And our other presenters are Alice Gunderson. She can introduce herself when her slides come up. We also have Guy Phipps, who may or may not be joining us. He's the Executive Director of Clinical Services at St. Francis Medical Center, and he's handling a crisis right now, but he's listening in, so hopefully we'll be able to hear from him later in the presentation. And Derek Drake is not going to be joining us today. His grandfather died, and so the funeral services are today, so I would ask that you would just kind of keep him close to your thoughts and heart today as he and his family are dealing with their grief and loss. This is pictures of our beautiful hospital campus, which you'll see throughout our presentation. And I just love looking at it. And it brings such beauty to the community that we wanted to share a number of shots with you. These are our learning objectives, which you should have had an opportunity to see during the registration process, but you'll be able to describe the merger and acquisition process and the impact on the organization. You'll be able to identify the role that patient family advisors play during and after merger and acquisition transition. And then you'll be able to describe how PFAC, Patient Family Advisory Council, and a hospital can pivot to remain engaged during the pandemic. One of the things that I would like to ask you to do at this point.
Marilyn, I'm sorry, we can't see the slides.
Okay.
I think you stopped sharing.
Okay, sorry about that.
That's okay.
All right, there's learning objectives. So one of the things that I would like to ask you to do is to identify in the chat, just put a brief note in there about why you chose this particular session. What was your interest? Because there are so many good sessions to choose from during these 2 days. Why did you choose this one? Because I'd be interested in knowing that, and we can kind of review those as we go along. St. Francis is one of the largest disproportionate share hospitals in the nation. It's the only comprehensive medical center in Southeast Los Angeles that was a nonprofit healthcare institution, but is now a for-profit healthcare institution as of 2 weeks ago, I think. The medical center has 384 acute care beds. It has one of the busiest private emergency and level 2 trauma centers in LA County, serving around 70,000 patients a year. The Family Life Center has a state-of-the-art neonatal intensive care unit and has its own building to provide maternal services. There's a psychiatric service line that's being expanded. The hospital has a STEMI receiving center and a primary stroke receiving center. There's a health benefits resource center to help folks with linkages to the community and for insurance coverage, and a children's counseling center. Right now, the payer mix is for the hospitals about 50% Medi-Cal and 1% self-pay. That's actually improved since the last time that we did a presentation like this, where it was about 70%. So that's good for the community. Looks like I'm actually not sharing, doing the slide presentation. There we go. All right, so I thought that I would take us down a little bit of history, because I think that that's important to the context of where we are today as St. Francis Medical Center in at the tail end of the last merger and acquisition. In 1945, the hospital was built. Believe it or not, it was built for $750,000. And the federal government kicked in about $400,000 of that. So think about the value of that in today's economy and transactions. It was built in response to a post-war population surge in Southeast Los Angeles, and really was a community effort that was collaborative between local leaders, including a Dr. Cooper and Monsignor O'Dwyer from the Archdiocese of Los Angeles, and the Sisters of Penance and Charity of St. Francis were asked to run the hospital. And since then, the hospital has been a Catholic hospital for a number of years, and we'll talk about why that's important. They had 150 beds when they opened, and they took care of over 5,000 patients in the first year. Fast forward to 1981, the Daughters of Charity were the assumed leadership of St. Francis. And 4 years later, Sister Margaret Keaveney became the CEO. During that time, there was a big renaissance of the hospital campus. And so, what you saw today in those pictures, which is just a small portion of the campus, it became a reality during that time, including separate buildings for the patient tower from the original hospital, the medical office building, the maternal child health building, et cetera, including a new emergency room and health services pavilion. So a lot happened during that time of Renaissance. And one of the things that I would like to point out is that Catholic hospitals are almost always built in communities where there are people who are poor, where there are immigrant populations, where the community is underserved. And that's an important point as we go forward, looking at the history of being a Catholic hospital and then becoming a community hospital that was non-profit for a while and now for profit. So in 1995, the Daughters of Charity merged with Catholic Healthcare West, which is now what became Dignity, became Catholic Health Initiative, merged with Catholic Health Initiatives. And so there's a lot of merger and acquisition going on there, with people who were our partners in 1995. As you can see, a few years later, the Daughters of Charity of the West withdrew from Catholic Healthcare West and became their own health ministry with 7 hospitals, of which St. Francis was one. The interesting thing is that the Daughters of Charity have been in California for over 150 years doing healthcare. They established the LA Infirmary, which was St. Vincent Medical Center, in 1856. And so, there's a long history, and you can kind of see the little insert there that they, founded, the San Jose Sanitarium, which is O'Connor's Hospital, and, Mary's Help Hospital, which is Seton Medical Center. So a long, long history of serving the underserved. So after nearly 70 years of Catholic healthcare, for-profit consideration was given. This was a big decision by the Daughters of Charity to take a look at this. And you might ask why. And so the first context is literally that situation where, the hospital was built in an area where there were folks that needed care, they were underserved, they were poor, there was not a lot of healthcare coverage. And so, providing a lot of charity care built up over the years, created, a situation where it was not fiscally possible to be able to continue in the same way. The other thing to know is that there were, at the same time going on, changes in reimbursement, changes in inpatient hospital utilization, where, the inpatients were decreasing while, outpatient services were kind of holding steady, but not necessarily growing. There were increased, system operating costs, which, included, labor costs that were 70% of revenue compared to the industry, which was at about 40 to 50%. And when you think about, hospitals, the biggest costs are supply and equipment or labor. So that's pretty significant. And then the managed care contracts were really poorly paying. They were paying less than Medicare and Medi-Cal. So, the question is, at this point, how was Prime chosen? Because this was the first go around at looking at a for-profit consideration. So 133 parties initially expressed interest in the Daughters of Charity Health System, but not very many submitted bids after conducting due diligence. The options were narrowed to 4 finalists, and all but one offered to buy the health system. And there was no other combination of offers for individual hospitals or other assets that equaled the strength of the full system bids, and Prime Healthcare's bid was superior at that time. So that's where the consideration came for Prime. Now, this slide is a little bit controversial, and that controversy played out in the media. And so, as you can see, we've got this headline that looks really pretty awful. But we need to recognize that there was resistance from the unions, from the city, from other officials, from the staff, and daily this played out in the media. But one of the things that we do know is that Prime Healthcare is known to save struggling hospitals. They allow those hospitals to continue to exist to serve the communities that need them the most. And then they increase the quality of care that's being offered so that they've received national awards and recognition for quality outcomes. So when you think about, this sort of tension, in the media and, in what goes on inside of the hospital and the health systems, there's recognition that the hospitals are generally in a better place as a result of this merger and acquisition. So I thought what I would do is share some milestones from this, 8-year journey, which really has been like a 40-year journey. When you think about all of those changes that happened early on, even with, the Sisters of St. Francis and the Daughters of Charity and CHW and all of those sorts of things. So we first started talking about a merger and acquisition and created an affiliation agreement in December of 2012 with Ascension. That didn't pan out, and you just saw the slides where we saw that Prime Healthcare was the highest and best bidder for the system, and a new transition agreement was forged. Then in February and March of 2015, the Attorney General really sort of gave the transaction a hard time, to put it in sort of general terms and not get too specific. And so Prime backed out. They said, you know what, we're not going to deal with these, Attorney General conditions. So in July of 2015, Blue Mountain and Integrity Health came in with a new transitional agreement, became Verity Health System. And at that time, that was December of 2015. The following year, in a few months, the Attorney General Local Governing Board was created, and PFAs were recruited to those board positions to represent the community. And that's a really important thing because, when the Attorney General requires community members to be part of a local governing board, they don't specify who they necessarily need to be, but it was felt very strongly that our patient family advisors were the people who represented the community best. And so we'll show you who those folks are in a little bit. So then, about a year later, a little bit more, Dr. Patrick Soon-Shiong came in and became a major stakeholder in the system, and an organizational transformation began and then ended. And so we moved forward to August of 2018, where Verity files bankruptcy. Okay, so a lot happened in between there, but that transition did not fully occur, and the health system filed bankruptcy and went under Chapter 11 protection. In December of that year, the asset purchase agreements were approved for the 2 hospitals up north, O'Connor and St. Louis, and then in January, KPC Global bid on the 4 remaining Verity hospitals. That bidding competition was approved. KPC won the bid. However, just about 12 months later, KPC chose not to close the purchase and alleged that Verity misrepresented. So in January, St. Vincent Hospital closed as a result of that merger and acquisition not going through. It reopened as the LA Surge Hospital. That's a story for another time. And the bidding process reopened with Prime Healthcare winning the bid for St. Francis and AHMC Hospitals winning the bid for the 2 Setons. Finally, here we are, in August of 2020, the bankruptcy court approved Prime as the best and highest bidder for St. Francis Medical Center, and also approved those bids for Seton and Seton Coastside by AHMC. So as you look at this, I want you to keep in mind, like, all of this change that's going on and all the communication that needs to occur, what is the patient and family role in all of this, and what's really happening at the organization. So what happens during an M&A is that there is fear of making the wrong decision. So, while there's hope and while there is, a bit of risk taking that's occurring, there's fear of making the wrong decision. And, so you look at, anticipating what risks might occur. you look at what risks you really want to avoid, and then figure out what sort of risks make sense to take in order to save the organization. We had a system that was no longer a system. Folks had left, overhead was reduced, and there was a lack of support for the hospitals. Some of that support needed to be grown from the ground up in those hospitals because the system had provided services that were important. There's inertia and paralysis, in operations, in decision making, in business development, and in contracts. And so, new contracts don't get initiated during this time, even though there might be, a need for that. There may be lack of growth, although I will point out that St. Francis did experience some growth during this time. They became baby friendly from the World Health Organization. They received that designation. There was the STEMI Center was created. Not only was the primary stroke center created, but it has achieved award-winning status, and as well, the diabetes certification by the Joint Commission was also put in there and was able to be achieved. So St. Francis was able to achieve some growth. And I know at times there were so many patients in the hospital that they were wondering when they were going to be able to find beds for those that were coming in. So there was inpatient growth at this point, but a lot of times that does not happen and didn't necessarily happen with the other hospitals, hence St. Vincent's being closed. So, there's further financial decline. There's a decrease in cash on hand. There may be the threat of or actual bankruptcy. There may be, vendors and debtors who are, refusing to meet the contractual agreements because they aren't getting paid on time and that sort of thing. And that happens in any organization that's going through a situation like this. There's repeated culture shock. There's all these definitive transitional agreements that are all different. So the culture begins to change, and then it changes again. And so folks in the organization may not know exactly where we are in the situation. There's a brain drain. Leadership turns over, medical staff leaves and gets privileges elsewhere. Frontline staff are looking for other jobs and may get more than one. There's difficulty with recruitment and retention. There are folks who say, you know what, call me when this merger is over, so I know that it's solidified. There's disruption in services. We talked about that a little bit. And then the impact on relationships with the community, with the local legislators, and with the collective bargaining agreement. So that's a lot of change and a lot of impact on the organization. So I'm going to be filling in for Derek's presentation, so I'll just move on. And this focuses a little bit on mergers and acquisitions across the nation, because this didn't just happen to St. Francis or Verity Health. This has been happening across the nation. So in 2017, there were 115 transactions, which was the highest number in recent history across the nation of merger and acquisition, which I will shorten by saying M&A transactions. The 32% of those involved, for-profit entities driven mostly by tenant, quorum, and community health systems. And a lot of that happened on the East Coast and the Southeast, which you'll see when I show you the map. Fast forward, so the value of those M&A transactions nearly doubled from 2016 to 2017. And as you can see, there's a very nice step upward to show that each year, other than 2016, literally there were more and more beginning in 2010. In 2019, it slowed down. You can see the trend line that shows that kind of went up and it went down and it went up and it went down. But in 2019, that quarterly volume of announced acute care hospital M&A activity reached its lowest point since 2009. So things were starting to slow down a little bit, even though some of those mergers were larger. This shows hospital bankruptcies across the nation in 2019. And unfortunately, Derek could not find a slide that showed 2018. But if you look at it, it's sort of a scary, map showing that, all throughout the Southeast and the Northeast, there's a lot of these bankruptcies that are going on. we don't show up on in California because this map is from 2019 and our bankruptcy was declared in 2018. But just realize that we sort of joined the ranks between 2018 and this time frame. This is what happened during COVID. So even though hospitals were full, they were in desperate needs for beds. And acute care hospitals were, looking to overflow into surge hospitals, and et cetera. The number of bankruptcies continued to grow. So this is the what was in the headlines, during this time of COVID-19. The thing to know is that the federal stimulus funds and the payment for COVID does not cover costs. I spoke with a nurse in one of the hospitals in New York that was in the middle of the headlines because of just all of the things that had happened during COVID, and they finally got their stimulus funds last month. So January to August, basically they're operating without getting relief or payment for that, and it really did not cover their costs. Made life a little better, but it did cover costs. So I'm going to switch to talking a little bit about the role of the PFA. And basically, there's great respect for the role of the PFA at St. Francis. And I don't say that just because, I've been involved in it since 2010, and because I'm presenting Derek's slide. This, is something that we hear and see all of the time from senior leadership, from the medical staff, and from the the staff and the leaders that we work with. So, what's recognized is the importance of patient-family involvement in healthcare decision-making. The strengths and priorities and preferences that they bring to the table that are unique to each family. And there's an encouraged partnership between patients and families and health professionals. And you'll see in the picture that Alice and her sisters made these little gift bags full of goodies for Hospital Week, and then joined with the leadership team to deliver them to the staff. And so, that's something that was initiated by the PFAs. So this is a quote that I like that says, if we're going to engage them, that is, make an emotional commitment to them, meaning patients and families, we might start by listening to them more and judging them on the choices they have made less. Okay. So I like that because there does need to be an emotional commitment between patients and families and hospital administration. There does need to be listening and hearing the stories and understanding the situations that have occurred, and judging less about the situations that have been involved in them. So this slide I love because it's a great picture of St. Francis on a cloudy day, but this depicts the health fair that was offered in 2019 that was initiated by a PFA. And if you can't guess who it might be, she's in the picture and she's presenting after me, but Alice, with her connections in the community and her connections to USC, Keck, and other organizations, including the Alzheimer's organization, and she'll tell you the things that she's been involved in, brought together this health fair to meet the needs of the local community. And one of the things that I did in preparing the slides was to go through the Facebook pictures that were posted about it, and looking at the children and the elderly, and the people of different ethnicities that came to the health fair and had their weight taken and their blood pressure taken, and their blood tested, and got information. And it was a really, really wonderful event that was initiated and led by a PFA. So that serves to highlight the bullets on the left-hand side. And so basically, PFAs are involved in helping to identify best practices, and they bring best practices to us. They serve in advisory roles. It's not necessarily an advocacy role, although I realize that that is a role that is played in other organizations, but it's an advisory role. They bring expertise in the form of their experience and a catalog of stories from which we can learn. And so that advisory role is very important. They participate to bring patient and family perspectives to committees, projects, and initiatives. They support the staff and leaders in those activities and initiatives. And they act as a sounding board, where as leaders can say, hey, what do you think about this? We're thinking of doing something like this. And, and that is really important that occurs at the front end, as opposed to, hey, we did this thing for you. What do you think? And it's like, you know what, not really going to meet our needs. And Alice is always very good about, bringing that perspective forward in a very nice way to say, you know what, we want to be involved at the beginning, because then you won't have to redo it. The representation is that the PFAs represent diversity, and they represent all patient and families' perspectives, and they take that role very seriously. They serve to evaluate the impact of patient-family-centered care on outcomes, and they educate. They educate us at every level, whether it's individually, whether it's on the PFAC, whether they promote patient and family-centered care throughout the organization with their presence, and they plan and participate in training nurses, new hospital orientation, medical staff, you name it. And for those of you who attended the previous session that St. Francis offered, you saw a video that has been used to train our No One Dies Alone volunteers. And so there's that training that that goes on at every level. I wanted to switch back for a moment to talk about the role of the PFAs on the governing board. And so I mentioned earlier about the local governing board that was put in place by the hospital to meet the Attorney General conditions. And Maria Carrillo, who's on this session, listening in, and Santiago Ortega, Senior, were the PFAs who have been representing for the last 5 years, the community to St. Francis Medical Center. And they're very good at bringing the community perspective and asking questions and saying, how will this decision impact the community? And really, helping the hospital to uphold and honor those Attorney General conditions from the first merger and acquisition, with Verity Health. So I will move on and then talk about, how PFAs are involved in advancing the strategic plan. So, we just saw an example of growth of the patient-family-centered care model beyond the walls of the hospital with the health fair. And I think that, that's only one example, and Alice is going to cover a few more of those. The PFA Council had balanced membership of PFAs and hospital leadership, and that occurred just in the last couple of years in terms of growth. Co-design became a primary construct, and I want to emphasize that it takes time to grow into true co-design, where literally there is partnership from the very beginning on agreed upon strategic initiatives between the PFAs and hospital leadership. So recognize that if you're on a PFAC or a PFA that may be starting out in your role, that co-design takes a little bit of time to grow into as the relationship grows between PFAs and the hospital. We recruited more PFAs, and we're working to do that. We actually created a video that is, contains PFA stories that is being put on the hospital website and hopefully on the patient TV channel to be able to recruit PFAs and to educate people on what patient-family-centered care means at St. Francis. There's been collaboration with the volunteer department to support key PFA initiatives, and we have PFAs that are on key medical staff committees. I love this quote by Dawn Berwick that says, "To reinvent healthcare, this new consumer-driven world, it's long past time to begin shifting power back to the patient." And so, creating these partnerships between patient-family advisors and the hospital and the medical staff and the staff, is evidence of that shift in power. So it's now my pleasure to introduce Alice Gunderson, who is our lead patient family advisor and who helped initiate the patient-family-centered care model at St. Francis Medical Center almost a decade ago. And she's truly a rock star, so she's probably the person you really want to hear. Welcome, Alice.
Thank you, Mary Lynn. Today, I would like to share with you, 1, the birth of PFAs at St. Francis Medical Center, 2, what mergers and acquisitions look like for us, the patients and families, 3, what our patient family council looked like prior to acquisition, 4, what our Patient Family Council is looking toward the post-acquisition period, and 5 lessons learned. St. Francis Medical Center adopted the Patient Family Center care model for the hospital, and in May of 2010, yes, that's been 10 years ago, Mary Lynn was hired as its senior director, and part of her responsibility was patient experience. Mary Lynn's doctoral thesis was on patient-family centeredness, and she was the architect of the St. Francis program. My husband Ed and I was what was called often in hospitals a frequent flyer. At the age of 48, Ed was diagnosed with myotonic muscular dystrophy and told he had 7 years to live. We lived closer to other hospitals, but due to healthcare providers at St. Francis, Ed lived not 7 years, but 21 to the age of 70. You see, Ed's physicians worked with him, not to or for him. St. Francis was our hospital of choice. Ed died in 2010. During those 21 years of building wonderful memories, Ed and I formed many opinions on how to improve patient experience as we traveled through the healthcare system. Ed's primary care physician, Dr. Harding Young, was also the chief of staff. After Ed's death, Dr. Young asked if I would like to share our experiences with the hospital. When first meeting Mary Lynn, she shared that her goal was to improve the patient and family experience. Well, she said the magic words, and as they say, the rest is history. In February of 2011, we had our first PFCC council meeting with our first 4 family advisors. We developed our mission and vision, recruited and made offers, and found advisors who succeeded and others who did not. We found we needed individuals who came from the outside, either as a patient or family member, with positive suggestions to improve patient care and services. They needed to have the ability to take a sow's ear and make a silk purse. We sought advisors who had a story, but were not seeking a support group, for we are not a support group. We developed relationships with the C-suite. Leaders were invited to PFAC meetings to share their mission and vision. We asked, how can we help? We rounded with C-suite leaders. PFAs were invited to be part of hospital committees. We served on bioethics, quality patient safety, readmission, nursing orientation, to name just a few. Some of the projects were the ICU Compassionate Listener Program, development of the hospital patient guide, faculty on the patient family faculty program, code sepsis, PFCC video project, No One Dies Alone, the Honor Walk, the Alzheimer's Dementia Support Group, which recently went virtual, and others. PFAs were from the community bringing experiences. We are partners to help improve the medical experience. It was throughout February 2014 to August 2020 when PFAs noticed and felt what an individual feels when there is a divorce or death in a family. But because of our already established relationship with the C-suite, the PFAC was kept abreast of what was happening in the hospital system. During this time, we did not lose any of our 7 dedicated PFAs. We partnered with administration and medical staff to assist the hospital during the transition by working from the inside out into the community where fear prevailed that their hospital could be shuttered and closed. PFAs took the CEO's message out into the community. We served as a conduit back into the hospital to share the community's concern. PFAs became advisors to and for St. Francis and partners with St. Francis Medical Center. Transition and communication was and is important. The CEO personally invested in PFAs. She came to PFAC meetings regularly to answer questions, dispel rumors, and communicated truth while providing support. The PFAC received the same communication as the hospital and system employees and at the same time. The PFAC received honest, clear financial data. The first and second post-acquisition attempts found us with many changes. Each CEO continued the already developed protocol and built upon it. CNO Derek Drake vigorously supported and built upon the foundation. He added the hospital director level to the council. This allowed decisions and follow-ups to happen quicker. Responsibilities and accountability were put into place. There were many changes in the hospital staff from 2014 to 2020. The Attorney General's office recruited the two PFAs from our hospital for the hospital governing board. Two PFAs were asked during the civil acquisition attempts to be questioned by the Attorney General's office, as well as represent St. Francis at the Attorney General's community town hall meetings. And the PFAC continues to meet virtually monthly since COVID. What is constant and did not change was one, the name of the hospital, which was important to the community. Two, the community. And three, the PFAs. In August of 2020, St. Francis was purchased out of bankruptcy by Prime, a 46 hospital, 14 state health system. As we look to the future, PFAs are moving forward to be part of Prime's 5-year St. Francis Hospital plan to hardwire culture, experience, and best practices. The PFAC Council is continuing from inside St. Francis. Expansion of the ICU Compassionate Listener Program to other units in the hospital. Expansion of the No One Dies Alone hospital program. Institute a 24/7 interfaith chaplain service. Distribute the film and produce PFCC video. Complete the patient family booklet, How to Be a Partner in Your Healthcare. We brought back into the community a Spanish Community Policing Advisory Board, the Living Well Community Education Series in collaboration with USC Keck and Rancho Geriatric Neurobehavior and Aging Center, the Hospital Video Research Project with CSU Northridge. As we reflect on lessons learned, the PFAC has learned: one, the importance of C-suite connection and its transparency. Two, the importance of true partnerships into the community. And three, the importance of personal experience stories. We knew how patient family stories are important when working with medical providers, but we learned that these same stories help when serving the community and talking with the Attorney General's office. And most importantly, PFAs are the community. Remember, even though ownerships change, leaderships change, staffs change, the PFAs are here to stay in the community. Thank you. At this time, I don't know whether Guy Phipps is on the line. I know that we had a emergency at St. Francis. So whether Guy will come on or whether Mary Lynn will come back on.
So I'll go ahead and just continue because Guy who is our Executive Director of Clinical Services, is still, dealing with the emergency at the hospital, and and that's what should happen. Patient care comes first, and patient needs come first. So he's where he needs to be. I will say that this is the ultimate level of trust to let PFAs represent the hospital nationally on a webinar. So anyway, we'll continue. These are lessons that were the lessons learned from the perspective of hospital administration. Leadership and PFA partnerships need to be transparent. They have positive results, and the relationship endures despite hospital leadership changes. And we saw that each time there was a change in leadership, and how the hospital leader learned about patient family centered care, was open to learning about patient family centered care, and was open to hear open to hearing from PFAs about what was important. The next lesson learned is that PFAs provide constancy and stability during times of chaotic change, and there was no attrition, so they stayed engaged. Patients and families are personally invested in their hospital and their health system, from grassroots movement to board representation. The PFCC model of care was maintained throughout all of these transitions, and actually didn't just survive, but endured and grew. PFAs supported frontline staff with rounds pre-COVID to cheer them up, as I mentioned before, bring them little goodie bags, bring them messages of encouragement. And what you see on the slide here is actually a letter memo, if you will, that was created by the patient family advisors that was sent to the hospital and distributed to every single unit in the hospital to send them encouragement. And so, and there were pictures of us, with our smiling faces, to cheer them on and to thank them for taking such wonderful care of our families who were in the hospital, of our loved ones. And this was something that was initiated by the PFAs, during the pandemic. There were other hospitals that asked their PFAs to do this, but this was initiated by the PFAs, which I think was pretty cool. And then the final lesson learned on this slide is that, that the PFAs provided insight during the pandemic to improve patient care. And so, from the PFA perspective, what was needed to address the issue, during this pandemic, including being part of designing purposeful COVID rounds. So here are some things that represent how the patients and families contributed, and the hospital partnered with patients and families during COVID, as well as some future things that we would like to see. So the hospital purchased iPads for physicians and staff to use to communicate with patients, and to hold patient-family conferences, to have conversations about serious illness and care decisions. If ever there was a time for advanced care planning and healthcare directives to have been important, was during this time, and many people didn't have them. So there had to be tough conversations about treatment, about palliative care, about end of life at a time when family couldn't be present to be with their family. There was a lot of fear about hospital-acquired infection. There were rumors that this was a COVID hospital, and yet the things that occurred in the hospital to make it safer, for patient and family centered care actually did occur. And we have a wonderful, wonderful infection preventionist who is very patient family centered, and made sure that some of those things that were done were communicated and had input from patient and families. So those iPads could also be used for, simply for communication. At times families would show up in the lobby and say, "What's going on? I need to see my family member." And, the nurse leaders would meet them in the lobby, talk about, updates, discuss precautions, and at times escort them to, the patient's room. There were definitely restrictions, as all hospitals had, on visitation, on family presence, but there was family presence in the labor and delivery area. The father could be present, as well as end-of-life care, particularly in the non-COVID patients. The process of developing COVID purposeful rounds came up as a result of wanting to make sure that the patients on the med-surg area were actually assessed, and that declining condition, deterioration was prevented. Lost my share for some reason. And so there was a patient family advisor involved in designing those rounds, along with the chief of medical staff, the ICU intensivist, the chief nursing officer, and a few other people. And so what the contribution was from the PFAs was that, that we want the nursing staff to educate the patient and family about, what is the disease process? There was a ton of stuff out on social media about what's really going on with COVID. What are the purpose of the medications and how do they work? What sort of testing and treatments could be expected? What symptoms might they be experiencing, and what should they report to the nurse, including any increased respiratory effort or shortness of breath, chest pain, feeling confused, having trouble staying awake, any new symptoms, so that that it could be caught early and that we could prevent decline. There is a plan for the direct care nurse or the social worker or the case manager or a chaplain to call the family once a day to provide updates, not as a result of people calling in and asking, but to actually do that in a preemptive sort of way. We talked about family presence and the communication from the had gone out from the community to the community from the chief of staff, the ED and maternal child medical directors to ensure that procedures and processes and care is safe. The PFAs provided virtual time input to policies and procedures as those policies and procedures. The into the future, sounds a little bit like that movie, Into the Future. What is anticipated to happen with PFAs and the hospital partnership after the merger and acquisition? One, we anticipate that PFAs will continue to participate in interviews of leadership and other key positions. As determined, by the hospital. They will continue to share the patient story at orientation, advance the patient stories to the huddles that occur in the hospital to build empathy and understanding about the patient experience. The goal is to develop more patient and family-centered policies and procedures. We'll have access to support resources, to corporate resources from Prime Health to support PFCC. We were very pleased to find out that Prime Health has patient family advisory councils across the nation. So we've already initiated some conversation to say, come attend our PFAC. We'll, come attend your PFAC virtually, and let's share best practices. So, that's already started. So we're really pleased. We've had active support and involvement from our Prime Chief Patient Experience Officer and her team. We have requested the potential for PFAs to provide input into the patient portal and the new EHR. That'll probably be a little while coming because it just started and switched from over from Arcus over to Epic. That's a potential for the future for open notes. There are, have been identified, there are resources for PFA recruitment and support, and PFAs will continue to contribute to the reopening plans and processes for the hospital. And I particularly liked this picture that I found that says we're all in it together, because that really describes what happens with patient and family advisory councils. So we have about, I don't know how many minutes for questions and answers. I haven't been opening the chat, so Laura, how do you want to handle the questions and answers?
Sure. So if you have any questions, you're more than welcome to put them in the chat or use that raise hand function, and I can see that your hand is raised and you can come off mute to ask a question. To find that in your toolbar at the bottom of the Zoom, again, it's in, if you click participants, you'll see a little blue raise hand. You're more than welcome to do that or add it into the chat. We'll give it a few moments to see if anybody has any questions.
And Laura, while we're waiting for that, when we're finished, before we log off, can you save the chat? Because it looks like there's some questions from folks that they'd like to learn more about what St. Francis is doing, and maybe we can contact them afterwards.
Yes, we will do that. And these, for the participants, these slides are on our website as well, on the event webpage. So if you need any of these emails after this presentation, you're more than welcome to go back and find them there.
So do we have any blue hands up?
Not yet.
Well, there's a question from Mary Schremke, if I said that right, who has an interest in supporting care teams that she works with, improvement processes as they manage through the changes that merger and acquisition brings, especially reorgs and how decisions are made. So how do we as patients know what the plans are? So I will say, respond to that in general, but I think Alice has some specifics that she could share. Essentially, it depends on the relationship that your PFAs have with hospital administration. Ours was very positive and inclusive and transparent. And so, as Alice mentioned, the hospital CEO would come to the PFAC not every month, but I think she was there, at least, once, maybe a couple times during the quarter, to share information with the entire council, as well as, she and Alice met together regularly. And we would get literally the information at the same time as the hospital employees were. So if there was an employee forum that was scheduled, was intended to give information to the employees, then the CNO would reach out to us and say, "You're welcome to join us," or "I will schedule a meeting to share the same information with you." So sometimes we might have even heard it before the employee forum, but there was real-time communication. So Alice, do you want to talk a little bit about how patients and families would know what the plans are?
Well, I think also, I noticed that Lou Rubino is on the chat as well. One thing was the hospital. I cannot express how important it is, the connection with the C-suite and the connection of often Mary Lynn and many of us have gone to, and many of you who have gone to conferences, you hear of organizations talking about that they are a patient family-centered care organization. One thing that we found at St. Francis was that even though we are a small group and we, our plans are definitely to grow larger as far as our base senior patient family advisors, the participation into and with the C-suite, we connected together. And Lou Rubino being the chair of the patient family, I'm the quality patient safety hospital committee, as well as being on the board of directors, was very open and actually was very encouraging for us to get involved. So I think as patient family advisors, we kept getting the support from senior leadership to participate. So it became easier. When you're building it, one of the things I would say, make sure you get as much exposure to the highest level that you can in the C-suite. Because if your connection is with a supervisor level, etc., it's hard to get to make changes, to be heard, for your patient experiences to be heard.
So there's another question that said, how did St. Francis begin to get the community involved to have events such as the health fair? I'll answer that generally, and then Alice can provide some more detail for that. But essentially, some of this was driven by the relationships that our PFAs have in the community. So for example, Alice could talk about all of the relationships that she had that led to the health fair. Paulette Bradley, who was one of the presenters at our earlier session provided, has very good connections with the city of Linwood, with the senior centers, that sort of thing. Santiago Ortega is a member of the Violence Prevention Committee, and I know that that's not the real title, but I can't think of the real title, for LAPD. So, some of those, connections stem from our interests in the community and our partnerships in the community. So Alice, do you want to respond more specifically?
Well, I think also specifically about the fair, St. Francis had always had community fairs while they were a nonprofit organization, and had been continuing that on. But as funds were getting less, and as things were being pared down, that was something that the hospital eliminated. And one of the things that we as PFAs, understanding the need of bringing the community into the hospital, because a lot of our families were leaving the hospital. So we wanted to bring the families back into the hospital, reintroduce people, or to introduce people that were not familiar with St. Francis. So we went to the executive committee and said, we would like to have this, but it needs to be funded. And with the lovely senior service director, Gilda Gonzalez, she really helped. She was the driving force of putting it together with all her connections into the city and everything, to bring this fair back into the community. It was wonderful because I think one of the things that what we got back out of it was that not only did the community know that the hospital was there, but also that the hospital knew the community was still interested. What was wonderful too, and this is hats off to Gilda, you know, the hospital has said that they will fund the fair, except she was able to come back where they actually made profit off of the fair. So, you know, it can be done, but it has to be done with commitment from both sides. We had many of our PFAs going out into the community to remind them about the fair, bringing them in. It was a cloudy, gloomy day, but we were surprised of all the people that attended, people that literally walked to the fair that might have been 2 miles away, but still walked to the fair because they heard it was there, because they had lack of transportation to come in. So, you know, if you can feel the heartbeat of the community and do what the community guides you toward, you will always hear their cry.
Laura, are there any blue hands up?
Nope. Not. All right. Thank you so much to Marilyn and Alice. We really appreciate you being here and presenting this session. It was very, very interesting.